Good afternoon, good evening, colleagues and friends, and I am delighted to welcome you to this webinar, The Role of Community Health Workers in Future-Proofing Health Systems in Fragile and Conflict-Affected Settings. And this webinar is through Health Systems Global, and it's an exciting collaboration between two of the Health Systems Global thematic working groups, the thematic working group on community health workers and the thematic working group on health systems in fragile and conflict affected settings. Next slide, please. So I'm Sally Theobald, and I'm based at the Liverpool School of Tropical Medicine in the UK, and I'm really privileged to chair the webinar today. We have a fantastic lineup of speakers, and we're really looking forward to also hearing and engaging with you, our audience, and our colleagues who have joined with us. So next slide, please. So how we will run the webinar is, if you have questions for the panelists, please submit those questions using the question and answer box at the bottom of the screen. The chat function is not available. Your camera and microphone are switched off, so no one can see or hear you. So please use that Q&A box at the bottom of the screen. And how we're going to run this is, we have these fantastic presenters. They're each going to present for 12 minutes. After each presentation, if there's any questions that come in that are for clarification, we will take those immediately after the speaker. But we're going to wait to the end to have the broader questions and reflections and experience sharing. This is a really important topic. We're looking forward to sharing. Please also share and amplify your learnings, your sharing, your experience using Twitter. And please, if you do so and are a Twitter user, these are the Twitter handles we'd love you to include. So Health Systems Global, and then the second one is the Twitter link for the TWG on community health workers. Next slide, please. So we want to find out more about who our audience is. So a very quick poll. So Nanuka, please, could you launch the poll? We want to find out what your work or study is related to: CHWs, health systems in fragile and conflict affected, both or neither. So please answer the poll.
So it seems the majority of our attendees responded to related to both, like community health workers and health systems in fragile and conflict affected settings. So 2 more seconds, I will close the poll and share the results with you.
Thank you, Nanuka.
Thanks everyone who voted. And here are the results.
Great. Okay, so we have a brilliantly experienced set of panelists, audience, looking forward to hearing more from you as we progress. Thank you for doing that poll. Next slide, please. Okay, so here is our lineup. So we know that community health workers play key roles in fragile and conflict affected settings. We've also seen the new challenges brought by COVID-19, revealing specific inequities in all health systems, including specific challenges in fragile and conflict affected settings. So fragility and conflict is not going away. So it's so important to learn from the evidence, learn from the experience of different settings. And as I've said, we do have this fantastic lineup of speakers talking to different issues and talking from different contexts around what can we learn about future-proofing community health workers in health systems in fragile and conflict affected settings. What can we learn to support this embedded cadre who are often under-recognized and undervalued? So we've got speakers that talk through different issues. So we know that there's so much to think about in terms of how do we improve integration between community health worker programs and the wider health systems to maximize the benefit of this partnership. How can we learn from the evidence and the experience of that integration between CHW programs and the wider health system? And Mushtaq Khan, health advisor from IRC in South Asia and MENA, will be talking to that. Secondly, we know that future-proofing of health systems will benefit from this agility, this flexibility of community health workers in different contexts. And Joanna Raven from the Rebuild for Resilience programme and Liverpool School of Tropical Medicine will be talking to us about that. We also know that community health worker programs in conflict-related contexts need to be able to work in contested, in challenging and evolving political contexts. And I'm really delighted that we'll be hearing from Thornay Tu, the director of the Burma Medical Association, on this, on the difficulties for CHWs and supporting agencies working in contested political contexts. And finally, psychosocial and mental health, it's riding high on the agenda. It's an issue that is so important, and fragile and conflict affected settings may present particular challenges for both the mental health of populations and for those providing support for those populations. So last but not least, we've got a double act from Andreas Lopsinga and Olga Rebeledo from International Organization of Migration, looking at their experiences of community-based psychosocial mobile teams in Northeast Nigeria. So please can you post questions for clarifications on the presentation, give the presenter's name, and also those wider questions and comments in the questions and answers. We really want this to be an exchange. We want to hear from all of you. We want to hear your ideas. And we will have some interaction happening later on. We're going to develop a Menti Cloud, and we're going to ask you to think about the key areas for priority action for future-proofing community health workers in health systems in fragile and conflict affected settings. So it's a challenge for you all, a challenge for active listening, a challenge for social media, a challenge to think about, based on all of our experience, what are those priorities for action? Okay, next slide, please. So please have your pens poised, ready for questions, ready for thoughts, ready for reflection. And I would like to kick us off then, without further ado, to welcome Mushtaq Khan, who is the health advisor for IRC in South Asia and MENA. He's going to be talking to us about integration between formal and informal community health workers programs and the formal wider health system in fragile, conflict and affected states. He's going to be talking particularly around Yemen, Syria and Jordan today, but I know from talking to him and reviewing his work online that he brings a massive wealth of experience from different fragile contexts. Mushtaq, we're delighted to have you with us. Welcome. You have 12 minutes. Thank you.
Thank you so much, Sally. Thank you. Hi, everyone. Good morning, good afternoon, good evening, wherever you are. So as introduced, I'm Mushtaq Khan from International Rescue Committee. So I'll be talking about the integration of formal and informal community health workers programs and the formal and wider health system in fragile and conflict affected settings in different contexts. So I'll be taking you all through different contextual experiences and learnings of community health workers IRC has been engaged with. And before that, I want to give you a a bit of a background so that it gets a bit of flow when I'll be talking about my experiences, what IRC has been doing in different parts of the world. Next, please. So progress on universal health coverage will not be equitable or effective without specific actions which has been taken in an FCAS. I'll be using this acronym because to save time, because we have only 12 minutes. So I'll be not taking the taking the whole name. So fragile and conflict affected settings, FCAS, and around 2 million people are estimated to live in FCAS. Now, the share of extreme poor living in FCAS is expected to rise from 17% of the globe total, which is today, to over 66% by 2030. And as a result of, and mainly as a result of shocks such as epidemics, earthquakes, climate change, man-made disasters, or just name it. In FCAS, access to equitable and quality health services is essential for rebuilding the social and economic fabric of the countries. But on the other hand, the health indicators are very challenging in FCAS, like 60% of the maternal child mortality is occurring in these settings. So to target this, we need to invest in healthcare workforce. And the healthcare workforce is a key component of health system that supports the expansion of health services and universal health coverage efforts. So most countries in global south have a shortage of formal, educated, trained health workers and are increasingly looking into a range of community health workers to fill this critical gap, and in particular reach the poorest and most marginalized communities. Community health workers are critical players in fragile settings where there is human resource shortages and challenges. Next, please. CHWs have proved to be essential, trusted, and first-line responders providing health services in settings affected by conflict or natural disasters before any outside support is provided, because it takes time. But they are readily available over there. So since they are readily available, so it's a matter of basic training, orientation to them to provide community-based services where formal health services or health systems are weakened or dysfunctional. Now, why we are engaging them? Because they are readily available as a local resource and also support to local communities who are equally affected by the disaster. And they are aware of local culture, norms, because they are going to be in the communities. So this helps to easily disseminate health messages and provide community level treatments, indoor, outdoor. Because of their selection, the sustainability aspect is also covered because they are from the same communities, and above all, acceptance at the community level, which eases the issue of access and gradual and continuous capacity strengthening. How? Now, about the FCAS people with basic qualifications are selected. We go for both males and female as they are part of our community health working programming to have access inside the houses in conservative communities and societies. Continuous training, monitoring, and supportive supervision to ensure continuous improvement of quality and expansion of topics which in the primary healthcare and cross sectors through integration. For example, primary healthcare CHWs provide awareness and messages started from communicable, non-communicable diseases, sexual reproductive health care services, mental health, epidemic, waterborne diseases, nutrition, basic treatment through ICCM approach, but they are also very much integrated into cross sectors, which include education, which include protection, ERD, and general protection, WP. So they get integrated very well in those cross sectors. They're actively involved in defaulter tracing. It can be TB dot program, it can be family planning program, so they can easily be used for defaulter tracking, and they act as a bridge. So they establish a critical referral pathway from the communities to the health facilities. And one of the lessons learned is that they should also take part in planning processes and emergency preparedness due to their local affiliation and understanding, which helps in a very contextualized health response, and this also promotes the ownership. So this is a big shortcoming in our programming when we involve community health worker for one purpose, but they are not involved in other critical areas. Next, please. Community health workers should not only be involved in post-emergency scenarios, but also in emergency preparedness and the recovery afterwards. So it is also evident that challenges faced by community health workers in fragile and conflict-affected settings are partly similar to the challenges that many community health workers face across the globe. Community health workers need support from the side of the health sector or health system or local ministries of health in terms of recognition, remuneration, continuous trainings, supportive supervision, general monitoring, and from the community side also through their selection and structures such as community level committees. So therefore, ministries of health and partners need to address the bottlenecks to community health workers service delivery common in stable low-income countries, as well as the additional challenges unique to humanitarian settings such as community health workers' safety, mental health, and access to specific communities. And longer-term fundings and integration of community health workers in national health systems should be prioritized to make this happen. Next, please. So you can see over here, the community health workers are in the center between communities and healthcare system, acting as a bridge. And there is a famous saying that people are lonely because they build buildings instead of bridges. So we need to bridge our health systems with our communities, and these are our best resources. Next, please. So I'll be taking you quickly through our some great experiences in different part of the world. I'll starting with Yemen. We started with general community health workers who are just providing health and hygiene messages, and gradually we worked on their communication skills and trained them on other PHC components, along with establishing referral pathways from communities to health facilities. The experience was good, but very slow improvements and results. Similarly, we started an ICCM programming in which we selected and trained community health workers from the host communities. We invested quite a lot, but when those community health workers returned back to the communities, they didn't get much acceptance from the communities, and we brainstormed on other options and did a mapping of locally available service providers, and there we came across a cadre which is known as community midwife. Now, why they didn't get community acceptance? Because they were from the same community. So there are pros of these community health workers, but there are cons also. They were from the same communities, they were selected, they were trained, but when they went back and started treating under 5 for ICCM treatments, including diarrhea, ARIs, and malaria, so people considering them that how can they become, they literally use the word doctors, that how could they become doctors with 14, 21, or 28 days training? So that it's really difficult that when you go to explain to the communities, and there comes your properly streamlined community health programming, that once you involve the community influencers, community elders, those people who have a big say, and then you start your community health programming, then you can always reach out to them whenever anything fires back, and if there is issues of acceptance. So that's where we worked along, and then we came across to a cadre by the name of community midwives through our mapping of local resources. Now, we started community midwives because they have huge acceptance in the communities. They were providing basic package of sexual reproductive health. So we engaged with them, and they started working along with providing the basic package of sexual reproductive health. They became our ICCM workers, and due to their huge community acceptance, and along with that, they also started providing health and awareness messages, and gradually we built upon their extended roles. So started from basic community, basic sexual reproductive health package, we built upon, and they become, we trained them, and then they become our ICCM workers, and provided the treatments at the communities, and also they started taking over the role of disseminating the messages related to all the areas under the broad umbrella of primary health care. So it really worked well, and we had a case study also presented in another forum that this adaptive management, which really worked well in our case in Yemen. Then I'll also share the experience of Syria, the northeast. There was a history of there that new concept for the host communities, as before 2011. For the past 40 years, the NGOs were not allowed to work in Kurdish dominant areas of Syria. We were getting general health programming, but we didn't face any challenge. We were easy to get doctors, nurses, midwives, but we struggled to find public health professionals. So over there again, we changed our strategy. Normally you hire and deploy, but over there, instead of hiring and deploying, we changed our strategy to hire, train, and then deploy, because there was no history of public health over there. So again, we struggled over there because of parallel health system. One was old Damascus-run health system, and then there was a new Kurdish healthcare system, both having their own pros and cons, limitations. So we were somewhere in between. Over there, again, we started from our community health component started with this community health programming and selecting these community health workers, both genders, with basic qualifications, which we outlined in their TORs, and they started with health and hygiene messages. With continuous training, monitoring, and supportive supervision, our CHW started providing messages on broader aspects of primary health care, communicable, non-communicable, sexual and reproductive health, nutrition, WASH messages, first aid treatments they were providing, and because there was active war going on just a few kilometers away, and monitoring of NCDs by testing blood sugars and hypertension. And they also established those referral pathways. And in the end, I'll be finishing with Jordan examples where we did the same, but we did also use the technology over there, where community health workers were actively reaching out to our NCD clients who cannot go to the health facilities because of COVID limitations, and they were provided with HIS on their mobile phones, where they can track the specific NCD client, and and then those tablets, they were linked with the main HIS. They are following up and dispensing their NCD drugs. This helps in treatment compliance and less exposure of NCD patient to health facilities. I'll be stopping over here because I think I ran over a couple of minutes. Sorry for that, but happy to take any questions. Thank you.
Thank you so much, Mushtaq. That was fantastic and a really clear overview for us about that embedded critical role of community health workers, that interface or bridge position between communities and health systems. And you talked about the community acceptability, the embeddedness, and also sometimes the missed opportunities for building on that embedded knowledge of community health workers in policy processes and in emergency responses. And it was fantastic to look across the range of contexts there: Yemen, Northeast Syria, Jordan, the different experiences, the innovation and the learning. So a massive thank you for that. That was an excellent way to kick us off in terms of who this cadre is, the opportunities and the experience in 3 different fragile settings. So in terms of question and answer, there's some experience sharing, but there's no actual questions for clarification. So I'm going to keep us moving ahead and look forward to further questions later. Please write them down for Mushtaq. So next up is Joanna Raven, who is a co-director of Rebuild for Resilience, also my inspiring colleague at LSTM. She's a health systems researcher and also a midwife. And Jo is going to be talking to us about the comparative agility and flexibility of community health worker cadre in fragile and conflict affected settings and contexts. So welcome, Jo. We look forward. You have 12 minutes and my timer is on.
Okay, thank you, Sally. What a challenge. Anyway, hello everyone, and very nice to be here to share experiences and learning from all of you and everybody on the panel as well. So this presentation is about the flexibility of the roles of CHWs in changing contexts. And I want here to focus on a study that we are just finishing that has looked at how CHWs have adapted their roles during the COVID-19 pandemic. And I'm presenting on behalf of this Rebuild for Resilience team. Next, please. So most countries in the Global South, and particularly fragile and shock-prone contexts, have a shortage of formal health workers and are increasingly looking to a range of CHWs to fill the gap and reach the most marginalised. And the COVID-19 pandemic has demonstrated the value of CHWs and their importance in this response. So in this study, we've particularly focused on the gendered experience of CHWs. So gender roles and relations are context embedded and dynamic, shaping the social determinants of health as well as the experiences of CHWs, and need understanding and addressing to appropriately support CHWs as they navigate new and existing challenges. Next, please. So we've conducted the study in settings in 4 fragile countries: Lebanon, Nepal, Myanmar, and Sierra Leone. Next. We've used 3 methods: reviewing documents and policies about CHWs in COVID-19, interviews and focus group discussions with CHWs. Now, there are a range of CHWs in each context, and therefore we selected in Myanmar female auxiliary midwives who work on maternal and reproductive health at the community level. In Nepal, female community health volunteers who support health promotion and prevention activities at community level. In Sierra Leone, these were CHWs who were part of the national CHW program, who deliver a package of services at the community level. And in Lebanon, we focused on Syrian refugees employed informally as health workers or volunteers at the community level. The third method was key informant interviews with managers, supervisors of CHWs, and community and district leaders. So drawing on the findings from these 4 settings, I want to present about the adapting roles of CHWs during COVID, the challenges that they face in taking on these roles, and the support that they need. So next, please. And next. So what we saw was a kind of layering of roles. So CHWs have their regular roles of general health education, maternal and child health care, clinical work, and so on. And on top of this, they had the COVID-19 roles, such as awareness raising, contact tracing, screening, referral, attending to people in quarantine, providing psychosocial support. We also saw a gender difference in the roles in some settings. So in Lebanon, men tended to hold posts with greater responsibilities, which often require more overtime and shifts, and women as the health educators. Myanmar, administrative roles were more likely to be taken by the men, whilst women were more likely to take on health education and prevention activities. Next, please. What was clear that clearly came out from the findings that there were many reasons why they were able to take on these roles. Community trust. CHWs were familiar to the community. There was a level of trust already there, and most were from these communities. They had existing relationships which enabled them to access families and marginalized people. They were willing to take on these roles as they saw it as their duty and in the time of an emergency, and could draw upon their links with community leaders and organizations to be able to do their work. They were also able to innovate to use local resources. For example, in Sierra Leone, they encouraged communities to use jerry cans as hand washing stations. The health system employers wanted to use them. They were seen as a low cost available resource. In Myanmar, the CHWs were the first to respond to COVID in the community. They were the first to give advice or give support. And in Sierra Leone, CHWs drew upon their experience of working during the Ebola outbreak. For example, how to talk with people and reduce fear, and how to do contact tracing. Next, please. But there are several challenges that CHWs faced in adapting their role, and these are from the individual perspective. So firstly, community gender norms in all the settings meant that women CHWs faced having to juggle multiple tasks of CHW work, regular and COVID, housework, looking after families, and homeschooling during lockdown. There was an increased workload. Again, this layering of tasks and roles. For example, in Sierra Leone, CHWs were expected to provide twice daily reports on families or individuals in quarantine. It was challenging when additional work came up unplanned. Women CHWs found this particularly difficult as they were trying to manage their homes and families too. Challenges in traveling to and from work safely were raised. In Myanmar, women have restriction, especially late at night, and need to be accompanied by their families. Men are freer to move. In Lebanon, public transport is unsafe for women CHWs. There's a risk of assault, especially in taxis, and it's unaccepted socially to be unaccompanied, especially when it's dark. Getting COVID-19 infection was a common fear, and this caused anxiety and stress amongst the CHWs. They viewed it as highly contagious. They had few safety measures and inadequate information to protect themselves. And there were no support mechanisms for anxiety and mental stress. There were halted or limited income generating activities, which was specifically raised in Sierra Leone, where there was a disruption in small businesses and other sources of income generation due to lockdown and travel restrictions and a focus on COVID-19 activities. There was also an increase in prices of staple goods. This led to increased stress, and it was particularly challenging for women CHWs who were widows or single parents. Next. Just let you have a look at those photos. And next, please. So family support was really important for CHWs to be able to fulfill their work roles during COVID. For example, in Nepal, family members assisted by completing household chores. In Myanmar, families helped with organising transport and accompanying them when doing their work. However, this support was not provided for all CHWs and in all settings. And this was because of the perceived voluntary nature of work without any form of benefits and monetary incentives. The concern around safety of CHWs themselves and their family members considering their potential exposure to COVID, and not getting the dinner on the table or not doing their household chores when the family wanted them to do. And this caused them to be scolded by their husbands and more elderly family members. CHWs sometimes developed coping mechanisms to accomplish both sets of responsibilities. So waking up early to complete household chores, ignoring the scolding. And despite supervisors knowing these challenges, there was little support from the health system to manage that. Next, please. And next, please. Stigma and discrimination from community members towards the CHWs themselves, but also their families. Community members were reluctant to listen to their advice and health messages and receive care. They were also isolated from any social activities. They were viewed as carriers of the virus. In Sierra Leone, some CHWs were accused of prolonging COVID so that they could receive more money. There was an assumption that they would be receiving good payment. Stigma and discrimination appeared to reduce as the pandemic continued. For example, in Myanmar, stigma was observed in the early phase of COVID, but as they practiced wearing masks and hand washing became more routine, there was less stigma seen in the second wave. CHWs were able to reduce this stigma and discrimination through talking with community members, drawing on the trust they had gained with them before the pandemic. Another challenge was the reluctance to listen to women CHWs. This was seen in Sierra Leone, Myanmar, and Nepal, where women CHWs struggled to convey message and advice to some men in the communities. In Sierra Leone, some supervisors paired women with men CHWs to try and overcome this issue. Next, please. And next. So there were several health systems challenges. limited training and supervision. In Myanmar and Nepal, reliance on informal sources of information and support, such as radio, TV, Facebook. In Lebanon and Sierra Leone, training was provided which helped them to understand about COVID-19, the use of face masks, physical distancing. In Lebanon, training was reinforced through online reminders. In Nepal, the supervision was done really sort of like mostly as a quick update with a phone call to the health post in charge, but no formal supervision was done. There was limited equipment and supplies, so PPE, masks, hand sanitizers frequently ran out. The PPE didn't fit, or CHWs often bought their own or often reused them. In Myanmar, not being prioritized for vaccination came up. There was also limited financial support for these additional roles, despite the policy saying so. So in Sierra Leone, CHWs were meant to receive $20 per week for COVID-19 response activities, but this was not seen as enough compared with workload, not being able to take on their usual income generating activities and the increase in prices of staple goods. Some didn't receive the allowance, others it was late or not in the full amount. In Myanmar, CHWs get some financial support from NGO programs, but nothing extra for their COVID-19 prevention activities. They paid out of their own pocket frequently for transport for household visits. And Nepal, most CHWs did not receive any kind of incentive or remuneration according to the COVID policy. They weren't aware about this policy and what they should receive. And key informants reported that allocation of limited budget at the local level was a major constraint to provide incentives to CHWs. Next, please. So finally, I see Sally there, CHWs need support to be able to adapt and take on these important roles during a shock like COVID. So families, they need their help in doing their work. So their household chores, transport, understanding. And this could be done through more communication with families, greater recognition from the health system and community for CHW work. Community needs to strengthen the links between community leaders and organizations to enable women and men CHWs to do their work and be supported in this, and not completely rely upon the CHW's relationships with individual communities members. We need to strengthen the training and access to information, and digital technology could help there with training and supervision. Incentives policy should be transparent and followed so that this doesn't damage CHW relationships with the community as seen in Sierra Leone. Providing adequate equipment and supplies to protect from infection, and mental health support and support to develop coping mechanisms, and a recognition of the need for this is vitally important. Thank you very much for listening. Happy to take questions. Thank you. Next, Tim. Yeah, thanks.
Thank you so much, Jo. Another excellent presentation, and you can see some of the themes building on what Mushtaq presented already in terms of community health workers, embedded relationships at the community level, meaning that they were in so many fragile and conflict affected settings, the first responders in response to COVID-19. And as we're seeing in the chat, Polly Walker has said they've been the backbone of that response. And you showed us very clearly across those 4 different contexts how COVID-19 has brought additional layering of roles and responsibilities. COVID-19 has also brought additional challenges to community health workers as they juggle that interface role between health systems and communities. And you also articulated how those challenges can be gendered and the ways in which community health workers have showed innovation and agency in responding to those challenges and what the recommendations are. So I've looked at the chat, the question and answers, there's comments, there's reflections, there aren't any actual specific clarification issues, but there's lots that we'll be picking up in our question and answer session that is coming after we've heard from our whole brilliant set of panelists. So I would like us to move on then, please, to our third presentation, and I'm delighted to welcome Sornay-Tu. So many welcomes. Sornay-Tu is the director of the Burma Medical Association. We're really happy to have you here, very much looking forward to learning from you. And he'll be talking to us about the difficulty for both community health workers and the agencies that support them in working in contested political contexts in conflict-affected Myanmar. Welcome. You have 12 minutes. Over to you. Thank you.
Sally, thank you so much for giving me a chance to share the our CHW program, which is in the conflict-affected areas, especially in the ethnic control areas. So next slide, please. Next. Here you see my presentation outlines. I will start with the conflict. The conflict, the root cause of the conflict in our countries. Well, can you go back, please? Oh, I see. Okay. So I will touch on the government, I mean the Burmese government CHW program, and as well as I also want to share with you about the community health worker trainings, which is being done in ethnic control areas. And finally, I will also share some challenges that we have faced, the CHW and the ethnic health organizations who are supporting CHW. Next slide, please. Okay. Also, yes. Actually, the first slides about the conflict. It's okay. It's okay. So this is the government's CHW programs. The CHW were trained to support the work for midwives in the sub-center. They are doing like community mobilization for the immunizations and advocates for safe water and sanitations. Of course, the provide the general health educations as well as the health awareness for citizens. For some CHW, they also can be able to treat some of the simple illness, which is the common diseases in the local area. Of course, they are trusted, they are accepted by the community because they are geographically, culturally accessible to the community. They are being nominated, selected by the community health committee, which is in the community, including like the process of the recruitments. There's no discriminations. They can be like a both or email. Sorry, the females and male can be recruited as a CHW. Next. See here the slides. This is the conflicts. Actually, this is the conflicts of the Burma, or nowadays we call Myanmar. Actually, it is not, the problem is not the simply the poverties or lack of democratic rules. It is actually the conflict over the 60 years ago, which is we call the payload agreement, that the agreement between the Burmese leaders and the ethnic leaders that want to aim to establish the Federal Democratic Unions of Burma. Actually, it is a broken promise, a broken agreement of the autonomy and power sharing. That is why the ethnic people have their own, developed their own health infrastructure over the last 30 years. Yes, please. I see ethnic health care system. Roughly, I show you the health and demographic information. So more or less like there are more than 700 people serving ethnic states and regions in Myanmar. Now, currently we have around about like 4,400 active workers. They including like health assistants and medics. There are more than 247 mobile health team and health facilities in across the ethnic states. What we do is like curative, preventive, promotive, especially also the mental health services. Please, next slide, please. Within the ethnic health system, there are three main key networks. Where the first one is like health information working system working group set up in 2002, aiming to collect and compile health information across the ethnic states to be able to use for the program planning and advocacy purpose. Second one is health convergence core group. This one is founded in 2012, right after the temporary ceasefire agreement between the government and ethnic armed organizations. So we thought our health organizations have opportunity that to engage with the government health officials to be able to reform the health system for the federal union of the country. And the last key network is ethnic health system strengthening group. We base on the WHO's health system framework, which is like 6 building blocks of the health system strengthening. So it's aimed to strengthen the ethnic healthcare system. Next slide, please. So I will skip these definitions of the community health workers because you all might already have know that the community worker, where they are, who they are, what they work. So I will skip it. Next slide, please. Okay, here we go. The community health worker training in ethnic areas. So in 2010, the ethnic health organizations and community-based health organizations organized the health policies system and development seminar. As a result of the seminars, we started like the EHO, ethnic health organizations, the community-based health organizations started to standardize the medical training and curriculum among the cross-border and border-based CBOs. So over the last 2 years of the policy seminar, the needs for the standardizations became evident. So now we have a medical training curriculum, CH training curriculum. Next slide, please. So you see here the training curriculum, we have 10 modules within, for the CH curriculum. We started with the anatomy and physiology and go down to the community health promotion. So you see here the photos that showing the CH, the community health worker training curriculum and manual for the training in the ethnic control areas. Next slide, please. So I will talk a little bit about the factors that influences the CH productivity and the retentions. Of course, the relationship between the health workers and community are very important. And the community recognize the CHW and adequate supervision incentive. Of course, the community values the CHW contribution to community. Of course, they are physically accessible, culturally sensitivity, and language-friendly services for the local people. They were born there in community and they live the community, they serve and they speak same language, dialect in the community. Next, please. So I will show the community health workers, so where they where they work, what kind of training, what duty they do, what kind of support do they have. Actually, after training of 6 months, the community health workers go back to their own area. They reside in the community health posts and the community health facilities that the ethnic health organization supports. So what kind of training do they have? Of course, we have ethnic health organization standardized training curriculum, which is the 6-month training period. At least for the selection criteria to CHW, at least 8 grades or standards of education should be necessary. Of course, they were selected from the community members. After the training, what can they do? They treat common illness, common diseases such as like diarrhea and dysentery. Of course, the community health promotions, community outreach, and also provide health education in the whole community. In terms of incentive, we do support from the organizations. We do support like 1,500 baht per month, which is equivalent to $40 US per month. At the same time, after the training, they've been for some years in services area. They also have another training. Next slide, please. Here, like community health worker training of trainers, in the left side. The right side is actually the community health worker training being done in the ethnic control areas. Next slide, please. It's being repeated. The slide being repeated again. Next slide, please. All right, this is the end of my presentation. So, what do we have to face? Because the unstable political situations, even now, it's more difficult, more worse because of conflict. At the same time, we have to rely on always on the international financial support. We cannot even set up the community health funds to continue the CHW program. Because of it, we have to always rely on the international support. Sometimes the insufficient incentive for the CHW is still there. So even if we set up the selection criteria for at least 8 standards, or still will be, because they come different ethnic areas. So even if we set up the 8 standards, it's that the education background is slightly different. That's why when you teach them the language, it's still difficult for us to do it. Thanks.
Thank you so much.
Excellent.
Again, another fantastic presentation. And again, as you said, these themes are reoccurring, aren't they, in terms of why community health workers are so pivotal in fragile contexts, in terms of accessibility, the physical accessibility, the cultural embeddedness, the language and accessibility there as well. And it was really exciting for me to learn about all the work that's being done, the range and the reach of the ethnic healthcare system, the training that you've put forward and standardized over the last 2 years, and the challenges that are playing out. And please accept my best wishes and my solidarity in terms of current challenges. And thank you so much for sharing with us about the pivotal role that community health workers are playing. So I'm just looking again at the chat. So again, Sorneti, what we're seeing is comments and similarities in other contexts, but no clarification points as yet. So I'm going to move us on and say a massive thank you and go to our last but not least presentation, which is a double act between Andreas Lopsinger and Olga Rebelido from the International Organization for Migration. Very much looking forward to hearing from you both about experiences of supporting community-based psychosocial mobile teams in Northeast Nigeria. So welcome. Between you, you have 12 minutes. Thank you.
Thank you very much. Hello to everyone, and thank you very much also to the other speakers for the very interesting presentation so far. So yeah, we're going to present to you today the work of IOM's psychosocial mobile teams in Northeast Nigeria and how the technical supervision of the PMTs is organized. I will start by introducing to you the composition and the tasks of the PMTs and IOM's technical supervision strategy for them, before Olga will then present practical experiences from her work in Northeast Nigeria. Next slide, please. So the PMTs are a standardized approach of IOM during and in the aftermath of emergencies to offer mental health and psychosocial support services in a community-based fashion. The PMTs are composed of a locally recruited multidisciplinary team, usually including a team leader, a clinical or counseling psychologist, a social worker, an educator or a teacher, an artist, anthropologist, or a sport coach, and a community mobilizer, who's usually a well-respected member of the community who functions as a focal point among the teams and the community. And depending on the context and at the needs at place, a health worker or conflict mediator can also complement the teams. The PMTs follow a participatory approach. So they are not only locally recruited staff, but are also identifying and facilitating mental health and psychosocial support activities by actively involving the community members and by trying to build on existing and rebuilding disrupted coping mechanisms on a community level. The PMTs allow, through their composition, for great flexibility regarding the activities tailored to the local context, and enable IOM to support and to reach communities over different phases of displacement. Next slide, please. So the support the PMTs provide is based on needs identified together with the affected communities and focuses mainly on layer 1 to 3 of the Interagency Standing Committee intervention pyramid, which means that the activities focus on the provision of basic services, for example, sharing information about existing services and how to get access to the services, community and family support activities, for example, socio-relational and cultural activities, such as sport and play activities for youth, for example, and also more focused services on an individual, group, or family level, provided by trained and supervised workers. So this could be, for example, emotional and counseling support. The PMT members also refer the people they work with to each other, depending on the needs, and to specialized service providers. As mentioned, the PMTs do not only provide direct services, but also try to strengthen community-based resources that are already there. Next slide, please. So the work the PMTs are doing is, of course, very demanding, with inherent and non-inherent stressors, such as the content of work, being confronted with the suffering of others, and also unclear roles, often, especially in crisis settings, mistrust by people they're working with, etc. So in addition, due to the community-based approach, the PMT members often live a double role, because on the one hand, they are helpers in their work life, but on the other hand, they are also members of the affected community themselves. And therefore, training and supervision is extremely important to ensure not only quality of the services provided by the PMTs, but also to maintain the well-being of the team members. So the objective of the technical supervision provided for the PMTs is the personal and the professional development of the supervised staff. Next slide, please. So the training and the supervision for the PMTs includes a training to prepare the team members for their job. For example, to provide them with knowledge about community-based MHPSS, because that's the approach used by the PMTs, about psychological first aid, etc. There are also monthly trainings on topics identified by the teams. So if they recognize that there's a specific topic or a specific need within the community, they will receive training to meet these needs. Last but not least, there's regular on-the-job training and technical supervision, for example, through regular meetings and field visits. And it's important to highlight that the technical supervision is not a management supervision. So it includes instead regular meetings with skilled supervisors. And the aim is to create a safe space for structured support and joint reflection among the team members. So the objective is to empower the teams and to work on their relationship with each other, to increase trust within the teams, and also to organize mutual support among the team members. And preferably the supervision is provided on individual or on group level. And if this is not possible due to remote locations, then peer or remote supervision is also an option. And in case the PMT members face personal, individual challenges, it's also possible to contact the staff care unit of IOM for personal support. By saying this, I hand over to my colleague Olga, who will now focus on the experiences in Northeast Nigeria. Thank you.
Thank you so much, Andrea, and thank you so much for inviting us on this webinar. I'm going to go through the basic programming that we have in Nigeria in Maiduguri and Northeast. So what we have established is 12 PMT that are regularly deployed to the deep field. Considering as well that the situation in Northeast Nigeria, due to security reasons, we have some challenges as well in terms of how to supervise directly our teams. But we have managed to establish a structure in order to guarantee somehow the connection between the teams in the field and our professionals in the office in Maiduguri. So we do have 12, as I said, 12 PMT deployed to the deep field, including psychiatric nurses, to able to address the different needs of beneficiaries in the context. What is important, I would like to highlight as well, that in the case of Northeast Nigeria, where is a protection emergency mainly, so we connect health and mental health concerns with the protection factors as well, which is very important because we have found indeed that the main risk that are putting in risk the mental health and psychosocial well-being of beneficiaries, especially IDPs, are related to risk factors. So we have the main structure as it is in this slide. We have the teams in the field. We do have project assistants that are appointed to supervise those teams. And then we have different irregular moments to collect the data, for example, in a weekly basis. In a monthly as well basis, we do assessments to identify the needs and concerns of our beneficiaries and to draft the work plans and to inform the activities that needs to be done in order to give a more relevant intervention for the beneficiaries. And also we have a monthly supervision that I'm going through very quickly on the next slide. Is about, we have individual sessions, group sessions, and case consultation meetings. So we established this structure in order to, as I said, to ensure on the one hand, as Andrea was mentioning, how we can build the skills of our members of the teams to improve as well the quality of the services that we can provide. So at the individual sessions, we have established some sort of a structure or the frequency as well that we meet with our teams in the field. So basically these sessions are led by a senior mental health professional, ideally a psychiatrist or clinical psychologist, and aims to provide a tailored and supportive guidance to individual psychiatric nurses, for example, to help them improve, to provide the quality of the services. And the frequency that we have in these sessions is we do have is assisted and is monthly, twice per month. So the idea is that the leader is meeting supervise individually the senior psychologist or the psychiatric nurses that are providing the counseling or providing the specialized services, for example. The other part is the group sessions. This is another type of supervision that we have established as well. And it's basically peer supervision, which is aiming to build a trusting professional relationship among the team members. And it's an opportunity for the team members to share practical solutions and pragmatic recommendations with each other. So it's promoting as well this peer support that is very important, considering as well as also Andrea was mentioning, and I would like also to highlight the security risk, the security situation in Nigeria is still very fragile. And so we need to also promote this type of supervision that is not relying on an expert or an external expert. So we need to build as well the capacity of the peers. And the case consultation meeting is basically a meeting that is aiming to ensure that management plans for individual clients are tailored in a comprehensive and integrated approach that reflect the views of both community-based workers and the specialized mental health providers. So the idea is to make sure that our intervention is not just medical intervention, but also the ones that are in need of a specialized assistance will be also provided by community-based activities. This is held as well on a monthly basis and is led by the senior program manager. Next, please. Our main challenges, and this is our last slide, and the main lessons learned that we had in Nigeria. So one of the things that we have found is we need to strengthen more the community mobilization capacity of our teams in the field, which is something that we are at the moment also doing, is that how we can increase these skills to mobilize and promote community ownership. Because as I said, sometimes and recently, for example, in the last 2-3 months, we have also faced some security incidents that had pushed us as well to evacuated some of our program, some of our PMTs from the deep field. So it means that we need to promote more the ownership in order to ensure that the continuity of our activities and the promotion of psychosocial well-being as well. We need to also increase the cultural awareness of our program, of our PMTs, to integrate more innovative responses to the strength and existing resources. And the part of the provision of direct psychosocial support that we do, we also found that some challenges in terms of how to increase the capacity, for example, to identify psychosocial needs and mental health conditions from a more comprehensive approach, trying to avoid pharmacological interventions standalone, and also interventions that are medicalized or basically medicalized and not considering the rest of the context and the cultural context. And also the integration of the family and the systemic approach is very important, and as something that we have been working, and we are going to focus more in the coming months in order to also improve these skills in the PMTs, to provide better response to the family as a system, and to increase as well our local partnerships for more sustainable support. And finally, as one of our main challenges in terms of supervision and evaluation is we try to establish this supportive learning and mentoring environment for the PMTs to acquire the knowledge and skills necessary to perform their duties. That's basically one of the things that we are focusing on, is one of our main lessons. And evidence-based comprehensive mental health and psychosocial support services through collaboration with other field teams, and build a medium for healthy teams, dynamics, and relationships, and ensure that mental health and psychosocial support services are integrated with other sectors' responses like child protection or GPV. So this is our last slide, and we are happy to respond any questions, any doubts, any clarifications. Thank you so much.
Thank you so much to Olga and Andreas. And I'm sure you'll agree with me, a fourth excellent presentation, and really important to look at how we can support community-based psychosocial and mental health support. And you've talked us through the experience of mobile teams in northeastern Nigeria. And Andreas, you talked about, again, this embeddedness, and how when we're looking at psychosocial and mental health support, we have to think about how community-based workers are part and parcel of the community, as well as being engaged in the response, and the personal and the professional training and support that's required. And also that ongoing thoughtful building of supervisory systems that are sustained and embedded in communities and responsive to conflict. And again, you finished there, Olga, with a focus on integration and the integration of mental health within the health system, leading us nicely back to the beginning of where we started with Mushtaq, with a focus on integration. So the questions and the chat are flooding in, but we'll start with just, can we go to the next slide, please, Tim? So what we want to do is to hear from the audience, to hear from all of us. We've had this incredible tour and learning of experiences. We've heard from Yemen, Jordan, Syria, Sierra Leone, Nepal, Lebanon, Myanmar, and Nigeria about the realities of community health workers' lived experiences, lives, and challenges in fragility overlaid by COVID. So we can see from the questions, from the comments, there's lots of experience, there's lots of reflection. So we want to hear from you. A quick interactive exercise. Please can you give 3 suggestions or recommendations, and they can be short, they can be brief, for priority actions that come to mind following these presentations. So if we can ask you to please, on a smartphone or on your laptops, go to menti.com, put in that code 51295460, and add your 3 suggestions or recommendations.
Sally, there's also a link in the chat box that may work.
Lovely, thank you very much, Tim. Well done, the first person that managed that. Okay, 30 more seconds and then we'll move on to the discussion. Okay, so thank you very much, colleagues, for doing that. And as we can see, one of the key issues is remuneration. That was key in terms of regular, fair payment. Also very key there was around integration within the health system, supervision, supportive supervision, ensuring that health systems can support this critical interface cadre. There was a lot of recommendations that came through in terms of support structures and processes, support for healthcare support, support in relation to risk and protection for COVID-19, and support for mental health. And then a final set of issues which were around trust building and advocacy, and how can we build on the embedded knowledge and expertise of this cadre to feed into planning, into partnerships, and advocate for this role to be well heard, well informed, and well supported. Okay, thank you very much for doing that. So we're now moving on to questions for speakers and comments. So please use the Q&A box. Some people have been using the Q&A box, some people have been using the chat function, and we have just over 10 minutes left. So what I'm planning to attempt to do is to summarize the comments and questions that have come up, and then go to each presenter in turn and ask them to choose 2 of those to respond to. Does that sound reasonable, presenters? In trying to be time efficient, but first of all, to comment that when you look at the chat and the questions and answers, there's a lot of comment there, comment of similarities between contexts, comments around issues of coordination in Yemen from Mohammed Ghalib, comments around similarities in gendered challenges in Mozambique, which Rosie Siege brought up, comments from Ethiopian colleagues around that juggling multiple tasks and how COVID brings another layer. Comments from Amida Baba around the need for health systems to better recognize and support this critical interface cadre. But let me now go to some of the questions. So please note them down, and I'm going to ask each presenter to respond to 2. So some are general and some are specific. So there was questions around the role of technology and unintended consequences. And thank you, Mushtaq, for giving a response to that in the chat. If you want to say more about that, you're welcome. There's less questions from Sophie Witter around what lessons have we learned from previous shocks for responses and support for community health workers, for example, in response to Ebola. How can we learn these lessons and get them to stick in future crises? Questions for Marisa Koch around, do we have examples of community health workers in any of these contexts responding to and addressing gender inequities and how they play out at the community level? So we heard from Joe about how community health workers' experiences can be gendered. Do we have examples of how they are looking to transform gender relations at the community level? There's a range of questions also about fair remuneration from Carrie Westgate. And again, there's been some back and forth in the chat about that, and it was interesting to see that remuneration and fair remuneration was such a key issue that came up in that word cloud. Questions around mental health support. What can we do to support community health workers and others that may not be part of PMTs? What's realistic? What's feasible to support mental health? Joe, there's one specific question for you from Irene Torres around community health workers' response to COVID. Was that planned or was that spontaneous? And then Thornay too, there's a specific question for you as well around community health workers from the ethnic health organisations and what they're currently able to do due to the current context. So I may have missed a few, but let's start with those because we don't have long. So over to you. Please choose 2 questions to respond to make a comment to. Thank you.
Thanks, Sally. I will definitely like to respond regarding the remuneration and the technology, which I did in the chat, but let me explain more. Yes, we do have challenges regarding the remunerations, and it is very common because every organization has their own budgets. Every organization have their own type of contracts they are offering to these community health workers, formal community health workers, informal community health workers. But to me, what works really well that if we have a strong hold at the health cluster level, because they are the one who are in line with the host ministries, and they are the one who are rolling out the packages for community level health workers. Because the issue is that when you train a cadre, you invest a lot of time, you invest a lot of money in that, and you train them on so many areas, and another organization comes, they offer them a more attractive package, and they just jump over there. Now that's really a big issue, that the brain drain from one organization to another because of unorganized remuneration packages. So that's what we were having back and forth communication, and then the role of cluster was really important in that. And if we have that, then also, like in our case of Yemen, where we extended the role of community midwives to many other roles. Now that is, we aligned our remuneration according to that package of services they are providing. So that's another case. But overall, CHW's role of cluster is really important. The technology part, which one of our colleagues they asked, yes, we do have challenges, because when you provide technology to community health workers, and there are not very strict SOPs around that technology, and you don't explain them about the do's and don'ts very critically or very logically or very in an organized manner, then there will be misuse of technology. But it happens when you start technology with CHWs, but with regular follow-ups, with supportive supervision, with vigorous back-to-back meetings with them, it tapers off gradually. And by the end of the day, we have to have a bit of comparative analysis, that what they are providing compared to what they are misusing. That happens. So we have to negotiate with that. We have to live with that. But at the end of the day, what they are providing, that makes a lot of difference. So yeah, I hope.
Thank you very much, Mushtaq. So Joe, please take the challenge of very succinctly choosing and responding to 2 of those questions, comments.
Okay, first one, the learning. How do we use that learning, and how can we get that to stick from different shocks and experiences so far? So it's clear to me from the chat box, from everywhere, that there's an abundance of evidence about the challenges that CHWs face globally, and then exacerbated in fragile and conflict affected settings, and then exacerbated through shocks as well. And I think maybe this is a really tricky question, and maybe it's a question to all of us on this TWG. It's like, how do we get this evidence to stick? How can we as a TWG do this? How can we convince health systems, governments, donors, to really recognize the critical role of CHWs during shocks. How can we take that learning and make sure that it's kind of, it transforms the health system so that the health system is able to use these CHWs at the time that we need to, but support them in that role. So I think it's a question to all of us to think how we're doing that, because the evidence is there and we haven't made that evidence work yet. So we've really got to critically think of that. So sorry, Sophie, I haven't really answered that. I've thrown it back to all of us. The second question was about Irene. Thank you, Irene. So I thought I'd better answer your question. And the response there is that, yes, for some of it's a mixture of settings. So in Nepal and Sierra Leone, the CHWs were part of the response. It was part of their role. There was some guidance about that. However, for Myanmar and Lebanon, that was more of a local response. And I can just give an example from Myanmar, where the auxiliary nurse midwives, you know, a lot of the who were seen as community health workers, a lot of the clinics were closed. So women were not accessing antenatal care or delivery care or postnatal care. And auxiliary midwives, these community health workers, went out to provide services to them, telephoning them and visiting them. And as they were doing that, they were taking on that COVID role as well. So it was a local response there. Thank you.
Thank you very much, Jo. Over to you. Sornetu, please respond briefly to one or two questions. Thanks.
I would say that there are two different health systems being implemented in Myanmar or Burma. One is implemented by the government, previous government, and not the state administration council. Another thing is like another system is implemented by the ethnic healthcare system. The ethnic health organizations. So to talk about the challenges, the CHW are being trained differently. The government system, they trained for 1 month in order to do their local activities like mobilizations of the immunizations, treat common diseases. But for the ethnic healthcare system, we trained at least for 6 months to be able to train. I mean, to be able to treat the diseases, the common diseases in the local area. So the CHW program is a part of within our healthcare system. The CHW training or program in the government, the programs, they are not within the system. They are outside of the system. So what I would like to see is that for the long run, the CHW training or CHW program have to be integrated into the government system, which will provide the basic healthcare needs for the primary healthcare services in the community levels.
Thank you so much, Sornetu. So last but not least, can we have a quick response from Andreas and or Olga, please?
Yeah, thank you. I can start. Olga, feel free to add to my answer. I chose the question regarding the lack of qualified personnel in many settings and how to provide psychosocial support there. So the approach that we presented is actually a community-based one, trying to re-establish and strengthen, support structures, social support structures, social networks that are there, because helping people to build networks that can stabilize people who are distressed can already make a huge a huge change in the benefit. So therefore, the approach is knowing the realities, focusing on low-level community-based activities. But it's right what you say. What is important is to have training, capacity building for the PMT members, and also to recognize that some services should not or might not be possible in certain settings. So if there's no psychologist available, then it's of course not possible to start certain kind of therapies, for example. And this should not be done. So knowing the limitations is important to not do more harm than actually help. I don't know, Olga, if you want to choose another question or add from your experience something.
Yeah, well, I think basically one thing that is important to address as well and to highlight is that the capacity of the health workers in the community has to improve and has to be a sustainable effort to provide a continuous support in order to, as I said, sometimes the capacity of the health workers in the communities are very low in terms of the technical capacities, and so it has to be a continuous effort to increase those capacities in the community workers, to actually ensure that we are providing a do not harm approach to the interventions. That's something that is very, very key, and I would add this just to the questions below. Thank you.
Thank you very much, Olga and Andreas. Next slide, please, Tim. So we've had a very vibrant discussion. We haven't been able to get to all the different comments and questions, and we do want to hear from you about suggestions of topics for follow-up, please. A follow-up set of webinars on community health workers and fragility. I think we heard a very strong suggestion of how do we get evidence to stick? How do we support health systems with evidence to respond? So that could be one. But please, colleagues, we want to keep this dialogue alive. We want to keep this experience sharing alive. So any suggestions for follow-up topics, please add them in the question and answer box, and the respective TWGs will review and do best to respond to bring those webinars to you. So please add any further suggestions. Next slide, please. We wanted to do a very quick final poll to ask, are you currently a member of the following thematic working groups? So Nanuka, please launch the poll. Thank you, Nanuka. And then for time, can we please go to the right? Okay, so we have some that are members of one, some that are members of the other, members of both, and members of neither. So just want to close by letting you know a little bit more about these two thematic working groups. So as we said, this webinar is a joint venture that pulls together these two different communities. So the health systems in fragile and conflict affected settings, thematic working group, and the community health worker thematic working group. And thank you very much to Nanuka, who's put the link to these in the chat function. These are engaging communities of practice who share experiences, who share evidence, who come together. So if you are not already a member of one or both, please do consider doing so, and please stay in touch with us with your ideas for future webinars. Please also share reports, ideas, papers. We want to be in a position to collate and to share and synthesize evidence in a way that is useful, in a way that supports health systems in fragility to better support this critical cadre who are central in fragility, and COVID has brought yet another lens to highlight their centrality as well as the challenges they face. So I would like to close then. Apologies, we've gone slightly over. I want to thank our fantastic panelists, and I also want to thank our brilliant audience for your participation and your questions. Please stay in touch. We look forward to working with you with future webinars and exchange, and go well with this incredibly important work people are doing to support and work with this critical cadre. Thank you so much. Goodbye.
Thank you.
Thank
You're
you.
welcome.
Hey, thank you,
Thanks a
sir.
lot.
Thank you so much. Bye. Bye.
Bye everyone. Bye everyone.
Bye. Bye.